Hey everyone, welcome to my Day in the Life series here on White Coats and Corgis. Most of you probably know me from Instagram or TikTok, where I make helpful free content for pre-meds and talk about my journey as a first-generation medical student. My mission here on YouTube is to give pre-med students all the information they need for a career in medicine. So in order to do that, I've teamed up with MedSchoolCoach to create this series where I'm going to do a deep dive on each medical specialty. And I want to start off by saying that it can be really difficult to accumulate the number of shadowing hours you really need to be accepted into medical school. And especially nowadays, this can be really challenging. A lot of physicians aren't open to shadowing opportunities in person the way that they were before. So that is why MedSchoolCoach decided to collaborate with over 20 doctors to give you a behind-the-scenes look at practically every specialty that you might be interested in. And this is all completely free. You can go to shadowing.medschoolcoach.com, register for the program, and then you get to choose whichever specialties you're interested in to shadow. At the end, you can fill out a short quiz, and then they'll give you a certificate of completion. That way you can count these hours on your medical school application.
All right, so the beginning portion of my slides is just a brief word about the field of urology and some of the logistics and highlights of what makes urology great, and then I'll go through two clinical cases that are not too uncommon in urology, and I try to make it as straightforward as possible, and so hopefully they're of interest. And so the urology day-to-day, Sam asked this earlier, what does the lifestyle look like? It really depends on your specialty. And so there's a lot of different subspecialties within urology, which is surprising because urology is already a pretty subspecialized field. But it ranges anywhere from general urology to pediatric urology, oncology. And the specialties that end up having more demanding hours are those that take care of sicker patients. So the oncologist, the urologic oncologist. Whereas general urology, men's health, female urology, a lot of that is outpatient based. And so I would say the majority of urologists are working pretty good hours. But regardless, it's still a surgical specialty. So the hours are, even as an attending, are pretty demanding. I put down here that 40% of urologists will complete a fellowship, and that's just to highlight the nature of the subspecialization of the field. And one great thing about urology is it is a mix of outpatient and inpatient. So you have clinic patients, and then you get to operate, and then some patients are admitted to the hospital, and so you get that really nice variety. I know that if I was in clinic 4 or 5 times a week, it'd be very tough. I'd burn out pretty quickly. And so having that variety of OR, outpatient, inpatient is a great aspect of urology that not a lot of specialties have. And another awesome thing about urology is we essentially own each organ that we take care of. So the prostate, the bladder, the ureters, the male GU tract. The kidney we share with the nephrologist. They'll take care of the medical portion. We take care of the surgical portion, but the surgical portion is much more fun anyways. Whereas everything else, we take care of both the medical portion and the surgical portion, which is really nice because, if you're a cardiothoracic surgeon, you have to share patients with the cardiologist who may be kind of impinging on your field with interventional cardiology. So those are some factors to consider in terms of job security. And there are a lot of different types of urologic practices, whether academic through university or public hospital or private practice group, whether they're large or small. The days of the single solo practitioner, especially as a surgical specialist is kind of dying because the overhead cost of being a surgical specialist that's solo is very expensive. And a lot of urologists these days are going into hospital-based employment. And so they don't own their practice, but they'll be employees of the hospital system. And so, this is not something that a lot of people like talking about, but your salary is a big part of your job satisfaction. And not necessarily because of how much you actually get paid, but how much you feel like you deserve, and how much are you actually getting paid? And so the highest likelihood of burnout is if you feel like you deserve to get paid more, but you're actually getting paid less. And thankfully, as a urologist, you're usually not hurting for money. It's probably it's always in the kind of top 10 of most well-paid specialties. But part of that is that urology is a surgical field, and you do typically work a few more hours than a medical specialist. And just a few points. Similar to OB/GYN, there is a gender disparity in urology. It's the opposite of OB/GYN, essentially, where most of the practicing urologists are male. And you see these percentages here. It's the rising percentage of female urologists. And I think this is something that the field is very aware of and wants to increase the diversity of our field. And so it's a great field for women. It's a great field for anyone, honestly. And so I know that we, as in my residency, we're very supportive of the women in our program and want them to be successful. And so this is just a thing that you should be aware of. I think any woman who's applying to urology should understand that there is a gender disparity, but it's not because we don't want women in the field. We definitely do. And so the training, it's a surgical subspecialty, and each urology program has anywhere from 1 to 5 residents per year. And obviously, this is drastically different from like an internal medicine program that has 50 to 100 spots per year. And that's part of the reason why it's so competitive, not necessarily because the field itself is inherently competitive, but because there are just such few slots. And there are 5 clinical years, including 6 to 12 months of general surgery during intern year. And depending on what you think about general surgery, those are some very good times, or they can be very bad times. But overall, intern year is actually probably the lightest year for any urologic residency. And each year, people say that each year gets better, and that's definitely been my experience. There are a handful of programs that are more academic that will include a 1-year research, usually after the 3rd clinical year. And on average, as a resident, you will work about 60 to 65 hours per week. And that's not including call. And compare this to a medical specialty, medical like internal medicine will work 50 to 60 hours a week. And so definitely there's an increased burden of work. And depending on what kind of program you go to, you may be on home call, or you may take in-house call, and whether you get a post-call day depends on that. But typically, as a junior resident, you're on call every 3 to 5 days. And so that's for your entire year. It's not just for one rotation, that's for your entire year. So because urologists are few and far between, we do have to cover, and we need, the call at every hospital is not super intense. And at my program specifically, I think that the call is difficult, but it's very educational. But the call burden definitely decreases as you become more senior. And there are many programs where you don't take any primary call as a chief resident, or you're in your final year. So for residents, for example, my program, we take home call. So we actually cover multiple hospitals from home. And then there are some programs, going back a second. When you're in-house, when you do home call, you don't get a post-call day. So theoretically, you could work all night and then work the next day, another full day. And so that's a danger of doing home call. But typically, programs will do this because the number of nights where you're up all night are pretty limited. And I would say for me, I'm probably up all night maybe 3 or 4 times a year. And so it's definitely not as common, but there is a risk of that happening. And then if you're in-house call, meaning you're in the hospital, you have to physically be in the hospital for the 24 hours or 30 hours, but then you get a post-call day, meaning the day after you get the day off, essentially. And so that's the difference. And it depends on what kind of programs you go to. The programs that are on the West Coast are typically home call, and then programs that are in the Central United States or Midwest or East Coast, where it's surrounded by the major hospital, like Hopkins, for example, or a Cleveland Clinic, they'll do in-house call because they only have to cover one hospital, not multiple hospitals. Okay. So I'm going to move forward into our case presentation now, unless Daniel or Sam, you had any questions. All right. So patient AS, she's a 20-year-old trans male to female with right testicular pain and swelling for 2 days. The pain had actually started prior, and actually she underwent 2 weeks of receiving doxycycline, and she stopped the antibiotics because the pain improved, but the swelling did not improve all the way. And then 2 days prior to the presentation to the emergency room, the pain and swelling definitely started getting worse. The patient did not have any fevers, chills, nausea, vomiting, anything like that. And the past medical history was significant for depression and suicidal ideation, although that had been better controlled at that point. And no other significant medical history. The patient was living alone in Seattle. And then it wasn't mentioned until way later after I visited the patient a few times that she mentioned that she was a trans female. The vital signs were pretty unremarkable, and on physical exam, the notable thing was a swollen right testicle, the size of the left, twice the size of the left testicle that was indurated and firm. And there was definitely some tenderness to the spermatic cord and the testicle. So the differential diagnosis at this point, the first thing we think about is more infectious causes, so acute epididymitis or testicular abscess. Other possible things are hydrocele, which is a fluid surrounding the testicle, testicular torsion, which is a urologic emergency where the blood supply of the testicle is twisted off and the testicle is at risk of dying. And then other things like an inguinal hernia or Fournier's gangrene is a necrotizing infection that usually starts in the perineum. It's not as likely to be this, but it's something that we keep in the differential. And then last thing was testicular cancer, given that it is a mass in the scrotum. And other workup was relatively unremarkable. She did have an elevated white blood cell count, so initially made me think that maybe this is an infectious thing. And then the 3 lab markers that you see here, it's AFP, beta HCG, and lactate dehydrogenase. These are all markers for testicular cancer. And so they were all within normal limits, so not elevated. So this is a testicle in ultrasound. You can see that the mass has pretty much invaded most of the meat of the testicle. This is normal testicle here. Oh, sorry. This is normal testicle. And so, there's only really two things that cause that: a really bad testicular abscess or infection, or more likely testicular cancer. And the diagnosis was cinched when we did a CT scan and we saw a enlarged lymph node in the retroperitoneum. And testicular cancer is unique in the sense that one of the most common areas of spread is to the retroperitoneal lymph nodes. And so you would think that because testicular cancer is in the scrotum, that you would actually have enlarged lymph nodes in the inguinal area, which is even closer to the scrotum. But because of the embryology of the testicles, which start in the abdomen and migrate into the scrotum, they're actually the most common areas for spread is the retroperitoneum, similar to where the kidneys are. Testicular cancer doesn't always have elevated markers, and so we can't definitely say that this is not a cancer just because the lab results were normal. And so in this situation, whenever you have an enlarged testicle like that with an ultrasound that's suspicious for testicular cancer, you have to take it out. And there is no role in testes biopsy, very minimal role of testes biopsy in treating testicular cancer, because there's the potential risk of seeding the cancer, where the tumor spreads along the needle tract. And so the standard of care of treating a testicular mass is a radical orchiectomy. This is done by making an incision in the inguinal canal and then taking the testicle out. We don't open the scrotum at all. We try not to, and we try to keep everything intact. And then we remove the testicle and all of its blood supply in block. And so we did the radical orchiectomy, and the pathology showed a classical seminoma. So there are really two types of testicular, or two categories of testicular cancer: seminoma or non-seminomatous germ cell cancers. I'm not going to go into the details of the two because I think that's beyond the scope of what we're talking about here. But that's what we saw. And then in terms of her staging, she was PT1B because of invading the Redes testes, and N1 because of the invasion into the retroperitoneal lymph node. So these are some testicular cancer facts. And the most common presentation, which is actually not what this patient presented with, is actually a painless testes mass. You actually only have acute testicular pain about 10% of the time. So a lot of men will come in and they'll just have a silent mass and they'll just feel it just when in the shower or something like that, and they'll come in and it'll prompt a workup. And the most common time for a man to develop testicular cancers are ages 20 to 40. And so testicular cancer has a bimodal distribution in the sense where the most common is 20 to 40s, and then there's another spike in the 60s. And in 60-year-olds, if you have a testicular mass, there's a higher likelihood that it's lymphoma. Scrotal ultrasound is the best initial imaging modality. And a third of testes tumors were misdiagnosed as a epididymitis or hydrocele. So this is something that, especially as a primary care physician, that you don't want to miss. And if there's any suspicion of a testicular cancer, you want to ask a urologist to see what they think. Okay, so I'm going to move on to our second case presentation. This is a 65-year-old healthy male with a weakening urinary stream. He wakes up 4 times per night to go to the bathroom, and he is very unhappy about this. Anytime he pees, he feels like he doesn't empty his bladder all the way. He's never gone into urinary retention, which means he's always been able to pee, and he's never been in a situation where he couldn't pee and needed a catheter to drain his bladder. He hasn't had any urinary tract infections, no other medical history or prior surgeries. And we do an exam test. It's called a Uroflow, where someone pees into a sensor and it will calculate essentially the rate in which the urine stream is going. And he's peeing about 7 cc's per second, which is not very good for a man. It should be around 15 or so, 15 to 20. It weakens with age. And he has the post-void residual of 250 cc's, which that basically measures how much urine is left over in the bladder after going to the bathroom. And for most people with fully functioning urinary system, they shouldn't have any urine in the bladder left over. And something that we're willing to tolerate is about 200 cc's or so. And so he's kind of right within that range. It's elevated, but not dangerously elevated. So we know that this patient is not emptying his bladder all the way. And so based on these findings, we suspected that he had benign prostatic enlargement. Some people, you may see this as BPH, benign prostatic hyperplasia, but you can't actually make that diagnosis until you have pathology, because hyperplasia is a pathologic diagnosis. And so it's not definitely benign prostatic enlargement, but in this age group and based on his symptoms and his findings, this is the most likely cause. So we started him on a medication called tamsulosin, which helps the prostatic urethra open up. It kind of essentially relaxes the urethra so that the patient could urinate a little bit better. And he had some improvement in his symptoms, but he was still unhappy. A big part was the waking up in the middle of the night. It was just making him so tired the next day. And so talked to the urologist about different options, and especially surgical options. And so he was interested in a surgical option. And so one test that was performed prior to him pursuing a surgical option was a PSA, which stands for prostate specific antigen. And it's a somewhat non-specific prostate marker, but it helps urologists and other physicians diagnose prostate cancer. And his PSA was 1.4, which is within normal limits for a 65-year-old. But the reason why it's important to check this is because any prostate surgery for benign prostatic enlargement is not a treatment for prostate cancer. And so before we go and operate on the prostate, it's important that we rule out prostate cancer. And the likelihood of someone having prostate cancer with a PSA of 1.4 is very low. And so that's why we check that first. And indications for surgical treatment, there's multiple indications. And this patient does not necessarily have the first 5, whether it's recurrent infections or hematuria, which is blood in the urine. But the last one, which is the patient being refractory to medical therapy or unwilling or unable to use therapy. And so this last point is somewhat of a patient-driven desire to want surgery, then it is that patient is eligible for surgery. This patient could have continued to go on the way he lived, and it wasn't causing him a ton of trouble, but symptomatically it was bad enough where he wanted to pursue treatment. And so that's why a urologist would perform surgery. And so he had a transurethral resection of the prostate. This is about a 1 to 2 hour procedure, and it's done endoscopically with a bipolar loop. And so, and it can be done as an outpatient or inpatient. You do a 1-night hospital stay. So let me see if I can pull up this YouTube video here. Now we're inside the bladder, and this is where the junction of the bladder and the prostate is. And you'll see that instrument there that's called a bipolar loop. And it's basically a hot cutting current that allows the surgeon to cut tissue away. And the surgeon is basically opening up the urethra by cutting the prostate open. And you'll see that the prostate is not necessarily a defined organ per se. It's almost continuous with the bladder. But you'll see that how that extra tissue is definitely intruding into the urethra and decreases the lumen space for urination to happen. So I want to play it a little bit more. That's just an example of what a TURP is, or transurethral resection of the prostate. And I'll be honest, it's very, very satisfying surgery because you have this big old organ that you start shaving off. But like I said, that surgery is about 1 to 2 hours, and depending on the way you do it, the patient may stay inpatient for 1 night, usually with a catheter. And for this patient, the next day, he was able to have the catheter removed and emptied his bladder all the way. So his post-void residual was 0. And in the long term, he only occasionally wakes up once per night. He's been urinating much better, and he doesn't have to take any medication. He feels much happier with his symptoms. And then as an outpatient, his post-void residual was 15, which is very acceptable. And he's very happy, and he would recommend this surgery to anybody who's suffering with what he's suffering with. The great thing about urology is patients come in with very specific problems, and a lot of urologic surgeries are, I wouldn't say straightforward, but they are surgeries that are usually outpatient that can solve their problem. So for example, if someone comes in with a kidney stone, passing a kidney stone, we do a kidney stone surgery. We do it all endoscopically, no incisions. We use a laser to break up the stone. It's like playing a video game. And then the patient's able to go home the same day. This is a very similar type of surgery where we use a camera, we shave out the prostate, and the person's quality of life is night and day. Now, previously, this patient was getting up four times a night to pee, and now able to sleep through the night. That's a big difference. That's the difference of being on call and not being on call. And so that can definitely affect someone's quality of life. So that's one amazing thing about urology is that, if patients come in with problems, we can do something very tangible to fix it. And it's very fun doing it. All of these surgeries that we do are very enjoyable. Urologists will do endoscopic surgery, which is using cameras and small handheld instruments. And we'll do kidney stone surgery, a lot of different bladder and prostate surgeries using that. We do open surgery, like a classic general surgeon. We do robotic surgery, which is urologists are the pioneers of robotic surgery. And it's probably one of the funnest things. It's truly like a video game, except someone's life is on the line. We do microscopic surgery, and that's probably one of the technically more difficult surgeries, but we do that as well. So yeah, urology has a big variety, and that's what makes it so fun. Not only variety in the patient population, but the types of procedures that we do.